patterns of behavior, cognition, and inner experience exhibited across many contexts and deviating markedly from those accepted by the individual's culture. These patterns develop early, are inflexible, and are associated with significant distress or disability. The definitions may vary somewhat according to source. Personality disorders, defined psychologically, is the set of enduring behavioral and mental traits that distinguish human beings. Hence, personality disorders are defined by experiences and behaviors that differ from social norms and expectations. Those diagnosed with a personality disorder may experience difficulties in cognition, emotiveness, interpersonal functioning, or control of impulses. In general, personality disorders are diagnosed in 40 to 60% of psychiatric patients, making them the most frequent of all psychiatric diagnoses. These behavioral patterns in personality disorders are typically associated with substantial disturbances in some behavioral tendencies of an individual, usually involving several areas of the personality, and are nearly always associated with considerable person and social disruption. A person is classified as having a personality disorder if their abnormalities of behavior impair their social or occupational functioning. Additionally, personality disorders are inflexible and pervasive across many situations, due in large part to the fact that such behavior may be egosyntonic, therefore perceived to be appropriate by the individual. This behavior can result in maladaptive coping skills, which may lead to personal problems that induce extreme anxiety, distress, or depression. These patterns of behavior typically are recognized in adolescence and the beginning of the adulthood, and in some unusual instance, childhood.
Personality disorders Group B. Group B including 1. Borderline personality disorders. Borderline personality disorders, it's including instability in relationship, instability of emotions. He sees the different thing at the same time. He sees the good and the bad at the same person. So that they call the borderline. They also delivering self-harm. Perhaps some sort of borderline personality disorder patient started to scratch their skin or started to make inappropriate relationship with people around him. We can note borderline personality disorders in females more than in males. And as DSM-5, there is a common relationship between borderline personality disorders and some sort of anxiety and psychotic disease.
Regarding the terminology of personality disorders, we have three clusters of personality disturbances. We have a cluster A, cluster B, as well as we have cluster C.
Personality disorders are common and chronic disorders, and the patient or persons suffer from personality disorders more likely refuse to psychiatric help, and predisposing factors or predisposing to other psychiatric disorder such as conduct or substance abuse or schizophrenia or anxiety disorders.
There is certain diagnostic criteria, or there is a general diagnostic criteria for personality disorders. The first one is an important diagnostic item, that a personality disorder causes an enduring pattern of experiences that deviate markedly from what is expected from the client. The deviation actually is manifested by two or more of the following major domains of a client's life. It should affect actually the cognition, the interpersonal relationships, the impulse control, as well as the affect of our clients. And such deviation should cause marked distress for clients. And such marked distress for clients actually should cause a significant impairment of their social, occupational functions, or it affects actually the daily life of clients. and such deviation should be stable and persistent for a long time. The distress cause impairment for a lot of years for clients, and actually personality disorder, as we said before, it is measured on decades. It affects the life of clients for a lot of time. That is considered to waste the times of clients.
For the development and course, personality disorders actually are persistent and inflexible form of development, inflexible form for the personality traits. Usually it is a persistent pattern of impairment, which is lifelong, usually lifelong, and such lifelong inflexibility cause the impairment in all aspects of clients' lives.
The prevalence of paranoid disorders, it's about 2.3%, and the most recent studies achieved a very important result that the percentage of paranoid personality disorders, it's about 4.4% in general population.
For the gender-related diagnostic issues, actually we have certain personality disorders that are more prevalent among males. For example, the antisocial personality disorder. Other type of personality disorders are more prevalent in females. For example, the borderline personality disorder are more prevalent in females. For the differential diagnosis, actually, it depends on the cluster. We said before that cluster A personality, we may have more prevalent psychotic disorders. Cluster B, we may have more prevalent neurotic disorders in such cluster of personality. This also includes cluster C personality.
Personality disorders can be associated with difficulty coping with work or the workplace, potentially leading to problems with others by interfering with interpersonal relationships. Indirect effects also play a role, for example, impaired educational progress or complications outside of work, such as substance abuse and comorbid mental disease, can plague sufferers. However, personality disorders can also bring about above average work abilities by increasing competitive drive or causing the sufferer to exploit his or her co-workers. In 2005, psychologists Belinda Board and Katrina Ferguson at the University of Surrey, UK, interviewed and gave personality tests to high-level British executives and compared their profiles with those of criminal psychiatric patients at Broadmoor Hospital in the UK. They found that 3 out of 11 personality disorders were actually more common in executives than in the disturbed criminals. Histrionic personality disorder, including superficial charm, insincerity, ignosincerity, and manipulation. Narcissistic personality disorder, including grandiosity, self-focused lack of empathy for others. Narcissistic personality disorder, including grandiosity, self-focused lack of empathy for others, exploitativeness and independence. Obsessive-compulsive personality disorder, including perfectionism, excessive devotion to work, rigidity, stubbornness, and dictatorial tendencies. According to leading leadership academic Manfred F.R. Keats de Vries, it seems almost inevitable these days that there will be some personality disorder in a senior management team. Relationship with other mental disorders. The disorders in each of the 3 clusters may share some underlying common vulnerability factors involving cognition, affect and impulse control, and behavioral maintenance or inhibition, respectively, and may have a spectrum relationship to certain syndromal mental disorder. Paranoid or schizotypal personality disorders may be observed to be premorbid antecedents of delusional disorders or schizophrenia.
The signs and symptoms of different personality disorder depend on the personality itself. In schizoid personality, the withdrawn, not sensitive person with solitary hobbies are the most common picture, and other personalities. The issue here I'd like to discuss about the coloring of the presentation of other psychiatric disorders. For example, if I have depression or anxiety or whatever, if I have a ground of specific personality, X form of personality, Y form of personality. This will color the presentation of that psychiatric disorder, and it's present in a modified way by that personality. For example, if I have depression and I have a prodroma, or not a prodroma, a ground of obsessional personality or anxious personality, that depression would mix with this type of personality I'm having, it's coming with agitated form sometimes, or anxious form of depression, or mixed anxiety depression. I think that I'm having, although really I'm having a depression, and this anxiety part is part of the personality, not part of the depression itself. For that reason, the management and the selecting of the type of antidepressant differ from one person to another based on what? On the ground, I mean the personality type of that patient.
According to the Statistical and Diagnostical Manual for Psychological Disorders, personality disorders can be deviated into 3 groups. One of them, paranoid, group number 1, paranoid personality disorders, including paranoid personality disorders. Paranoid personality disorders, it means that the person have some sort of negative false beliefs, that people around him talking about him, and he has suspicious and doubts about people around him. Second pattern of group 1, schizotypal personality disorder. Schizotypal personality disorder, it means that there is disturbance of behavior during the communication with people around the patient who is suffering from schizotypal personality disorders. Type 3 of group 1, it's schizotype personality disorders and schizoid personality disorders. Schizoid personality disorder, it means that the patient may have some sort of odd behavior and odd thinking too, and also has some sort of delusion of persecution and delusion of reference. If the patient not treated who's suffering from type 1 or group 1 of personality disorders, he going to relapse and going to suffering from schizophrenia, especially undifferentiated schizophrenia and affective schizophrenia. Type 2 of personality disorders, or group number B. Group number B including borderline personality disorders, which mean that there is instability in relationship, instability in emotions. Patients who suffering from borderline personality disorders started to feel that persons around him against him. Some sort they make a comparison between good and bad, and they think that themselves suffering from this reality, so that they call the borderline, because it's not characteristic within neurosis and it's not characteristic within neurosis. Another type of personality disorders in group B, narcissistic personality disorder. Narcissistic personality disorders, it means that the person have self-centurionic and egocentrionics, that he focusing about himself, that he want everything to be obey his will. He want everything to be under his control, and he want all the people around him approval him and says a good sentence about him.
The functional consequences of personality disorders, as we said before, it depends on the type or the cluster of personality impairment. For example, clients with the cluster A personality, usually they suffer from semi-psychotic states. Usually they suffer from bizarre way of behaving and relating to themselves and to others. Cluster, for example, cluster B personality disorders, usually clients have comorbid conditions such as major depressive disorder. All type of anxiety disorders are more prevalent in clients with cluster B disorders.
If we spoke about the terminology associated with the personality disorders, we find that there is a certain classification for these disorder into clusters. So if we review those clusters and go through the certain personalities quickly, so just to highlight the terms associated with these disorders. There are 3 clusters in the personality disorder. The first cluster is known as the cluster A, and it includes the personalities which are the paranoid personality disorder, the schizoid personality disorder and the schizotypal personality disorder. So there's the paranoid personality disorder, there's the schizoid, and there's the schizotypal personality disorder. Moving on with the terms into the second cluster, which is cluster B, and it involves 4 personality disorders. One is the narcissistic personality disorder, the borderline personality disorder, the antisocial personality disorder, and the histrionic personality disorder. And all these disorders usually share a common theme, just like in cluster A. And finally, there's the cluster C, and it involves 3 personalities. One is the avoidant personality disorder, and the second is the obsessive compulsive personality disorder, and the third is the dependent personality disorder. And again, they all share the same theme or the same characteristics. Since we are talking about terms, let us define what a personality is. The personality is the pervasive pattern or characteristics that an individual has or possesses. It basically defines us and defines who we are to some extent. So a group of behaviors that we have and and the way we interact with others might tailor us into our own personalities. So these are the terms and these are the classifications of the personality disorders.
The prevalence of personality disorder, which is a common or chronic disorder, are estimated between 10 to 20 in general population, and some types of personality disorder more common in female, such as borderline personality, and other personality disorder types of personality disorder more common in male, as narcissistic or anxious and antipsychotic.
Some societies and cultures make some personality disorders more and more, and make the patient avoid looking for the treatment of a personality problem. For example, anxiety personality. When we have an anxiety personality in a society, because some of the societies, a very critical society, very domineering society, that type of anxious personality become worse with time. Avoidant personality, again in that society of criticism, this become more and more avoidant. Then there is a social coloring of the presentation of the psychiatric disorder in general and the personality itself. If the patient having anxious personality, avoidant personality, and he travel, for example, abroad for a study or something, he will not have the same symptoms or suffering like when he is living in his small town and his family members and relatives around him, and he under more attention and focus of others. When he travel, busy with his study and living with people, he don't know them, they don't know him, and in that way, the criticism, the feeling of inferiority will be much and much less. For that reason, his personality will progressively improve really and become more and more relaxed, and he can overcome that personality problem.
We still in cluster A of personality disorder. Cluster A in personality disorder also include schizoid personality disorder. Schizoid personality disorder, it's mean a pervasive pattern of detachment and lack of social communication skills and interactive with people around the patient. And also we found a poor and impairment in social communication skills, and perhaps the patient started to present a weird behavior and some sort of odd feeling and inappropriate reaction formation and reaction emotions. We can also find that almost always chooses solitary activity, and also the patient have a little friendship. Perhaps also the patient cannot make any friendship around him and started to induce some sort of deficiency in his social and occupational performance.
For the comorbidity, actually, all type of psychiatric as well as biological disorders should be ruled out. When we do the diagnosis, we have always to rule out all major psychiatric disorders as well as other biological disturbances which may cause dramatic change in the behavior of clients before we put the final diagnosis of personality disorder.
Now, in the regarding the differential diagnosis, personality disorders might be one of the most difficult disorders that a psychiatrist or a mental health professional might face, because they are sometimes confused with major psychiatric conditions. Let's take, for example, the cluster B personality, in which we have the borderline personality disorder, for example. Many physicians and psychiatrists might confuse the borderline personality disorder as, for example, a mood disorder, maybe a major depressive, and sometimes a bipolar affective disorder. So it is not uncommon for a psychiatrist to have difficulty diagnosing these disorders, and a differential diagnosis can be quite wide and difficult to pinpoint. Again, if you go with cluster A personalities like the schizotypal or the paranoid personalities, they might have symptoms similar to psychotic illness like schizophrenia or a delusional disorder, and the psychiatrist should take detailed history and dig deeper and rely also on the mental state examination of the patient to diagnose the patient accurately. Also, in cluster C, some of the personalities, like for example the avoidant personality, might be mistaken as a social phobia or a generalized anxiety disorder. So the differential diagnosis is quite wide in these conditions, and the physician should really pay attention to that, not also to neglect that comorbidities can exist. So a patient might have a personality disorder and also have a coexisting major depressive or an anxiety disorder.
If we focus about the diagnostic criteria of personality disorder, we have a three cluster in diagnostic criteria: cluster A and the cluster B and C. About the cluster A, it's including the paranoid personality disorder. The diagnostic criteria of paranoid personality disorder refers to some sort of suspicious thoughts and paranoid thoughts and feeling that the patient have some sort of doubts about people around him. Another thing, that he read hidden demanding in people around him. We can find that the patient also suspect in people around him, and this is make a disturbance in his emotions and the disturbance also in his mood, and this is definitely affecting negatively in his way of reacting and behaving with people around him.
There are numerous possible causes of mental disorders, and they may vary depending on the disorder, the individual and the circumstances. There may be genetic dispositions as well as particular life experiences, which may or may not include particular incidents of trauma or abuse. A study of almost 600 male college students, averaging almost 30 years of age and who were not drawn from a clinical sample, examined the relationship between childhood experiences of sexual and physical abuse and currently reported personality disorder symptoms. Childhood abuse histories were found to be definitively associated with greater levels of symptomatology. Severity of abuse was found to be statistically significant but clinically negligible in symptomatology variance spread over cluster A, B, and C scales. Child abuse and neglect consistently evidence themselves as antecedent risks to the development of personality disorder in adulthood. In the following study, efforts were taken to match retrospective reports of abuse with a clinical population that had demonstrated psychopathology from childhood to adulthood, who were later found to have experienced abuse and neglect. In a study of 793 mothers and children, researchers asked mothers if they had screamed at their children and told them that they did not love them or threatened to send them away. Children who had experienced such verbal abuse were 3 times as likely as other children who did not experience such verbal abuse to have borderline, narcissistic, obsessive-compulsive or paranoid personality disorders in adulthood. The sexually abused group demonstrated the most consistently elevated patterns of psychopathology. Officially verified physical abuse showed an extremely strong correlation with the development of antisocial and impulsive behavior. On the other hand, cases of abuse of the neglectful type that created childhood pathology were found to be subjected to partial remission in adulthood.
Regarding the associated features supporting the diagnosis, actually it depends on the degree of functional impairment. Personality disorders cause impairment in all domains of a client's lives. So the associated features which support the diagnosis usually depends on the degree or the type of impairments in clients' lives.
The differential diagnosis of paranoid personality disorder is related to the personality change due to another medical condition or other mental disease or psychotic features or psychotic symptoms, by the way, and the other personality perspective and disorders, and also about the anxiety disorder.
For the risk and the prognostic factors, actually, usually the behavior is the most important factor in determining the prognosis of clients with personality disorders. Sometimes we have such kind of behaviors that is socially inappropriate. Sometimes we may have some kind of impulsivity, and sometimes we may have certain behaviors that harm the basic issues in the client's lives.
There is a certain etiological factors for personality disorders. The genetic factors actually are implicated in a lot of such cases. Hormonal factors play a role in such disorder, as well as neurotransmitters theory in general. It's also implicated in the pathogenesis of personality disorders. We have also certain psychological factors. For example, the defense mechanisms are implicated actually in the pathogenesis of personality disorders.
There are many different forms of treatment used for personality disorders. Individual psychotherapy has been a mainstay of treatment. There are long-term and short-term forms. Family therapy, including couples therapy. Group therapy for personality dysfunction is probably the second most used. Psychological education may be used as an addition. Self-help groups may provide resources for personality disorders. Psychiatric medications for treating symptoms of personality dysfunction or co-occurring conditions. Myelotherapy, a kind of group-based residential approach, has a history of use in treating personality disorder, including therapeutic communities. There are different specific theories or school of therapy within many of these modalities. They may, for example, emphasize psychodynamic techniques or cognitive or behavioral techniques. In clinical practice, many therapies used an elicitic approach, taking elements of different schools as and when they seem to fit an individual client. There is also often a focus on common themes that seem to be beneficial regardless of techniques, including attributes of the therapist, processes afforded to the client, and match between the two.
There is a lot of pharmacological agents actually that targets the major criteria or the major pathological traits of the above mentioned personality disorders, the above mentioned 3 clusters of personality disorders. For example, we may have certain behavioral disturbances, for example, the behavioral discontrol, the aggressiveness, the impulsivity. And in this case, we may use certain pharmacological agents, for example, example, the lithium carbonate, the selective serotonin reuptake inhibitors. Sometimes we may use small doses actually of antipsychotics. This is an example of how we treat the pathological traits of personality disorder. According to the clinical manifestation, we usually target. The management of personality disorders generally not only include the pharmacological interventions, it should also include the rehabilitation, the psychological rehabilitation of clients, because as we mentioned before, it causes marked interference with the client's lifestyle.